Hi, this is Jim Hermiller for CardioTube from CRT2014. And we're very fortunate to have today with us Professor Hans Figulla from University Hospital in Jena, Germany. And Hans is going to talk about sort of the orphan valve, the one that we don't pay enough attention to and we need to pay, I think, more attention to, and maybe some solutions that have a transcatheter base. So Hans, thanks so much for being here.
Yes, thanks for being interested in that, what we also called forgotten valve, because I don't know, it's really forgotten. It's forgotten in the sense that we treat that valve because there are not that many options when it comes to severe heart failure, to right heart failure. As most of us know, I mean, when it comes to liver cirrhosis and ascites and so on, these patients are deferred by the surgeons. They can't do anything, and we treat them with diuretics, and then they come back to us and so on. So they are no option patients, and we considered what to do about. And there were some efforts in the past to place a percutaneous valve into the orthotopic position. However, that failed in the past because it's surrounding without any stiff tissue.
There's no anchor.
And
Nothing to anchor.
You can't anchor it. And so we considered to implant heterotopic valves, which is to reduce the backflow of the right ventricle, which goes into the inferior vena cava and superior vena cava, of course, and to reduce the volume load of the right ventricle. And we did a lot of animal experiments, and we induced tricuspid regurgitation in these animals. We made chronic animals and so on. So since 2010, then we published, and we were very much afraid when we began with to put these heterotopic valves into it, that they would thrombose, because there's, as you know, there's low flow rate there, but they never do. And so we went on with that, and we were happy to, in the end, we got research grant. It isn't commercialized yet, but from this point of view, we were then happy to do some compassionate cases in the humans, and they are quite successful.
Yeah.
That's it.
So tell us kind of the approach for this heterotopic valve. We're not putting it in the tricuspid position. Can you just explain it for the audience?
Yeah, it's a very easy procedure. It's much easier to position as is in TAVR cases. So and you have a straight line from the venous side on the groin upwards. As you know, there are no kinks and things like that. And we began with in the first patients with just to put the valve in the inferior vena cava to get rid of the pressure load to the lower extremities and the liver. But the volume the regurgent flow reduction was not that much for the right ventricle. I mean, the option is that the right ventricle will improve due to the volume reduction. So I have to say, once the patient is gone, so if the right ventricle is gone, it's enlarged and it has no V wave anymore. And so, of course, this is no option anymore, as in all other regurgitant valve cases. I mean, the same holds for the aortic regurgitation. So we looked at in the beginning that there is a V wave which is really elevated. There is still a functioning right ventricle, good contraction in the right ventricle, but just the patients complain about this backward failure. And so this to implant just one valve hasn't had the great impact. So then we began with to implant the valve into the vena cava superior and the vena cava inferior. Of course, you have to be careful not to obstruct the venous, the liver, the hepatic veins. So the valve is a little bit in the right atrium. It's above the hepatic veins, and that works.
Yeah.
That's it.
So you put, and it's a self-expanding valve?
It's a self-expanding valve, and those valves are huge. They are manufactured in Canada, and it's this pericardial valve. We also did some experiments now, animal experiments with decellularized valves, and they never thrombose. In all our cases, they never thrombosed. Of course, we put them in anticoagulation, these patients. And it helps for the right ventricle to restore, because of you get rid of some part of the volume.
The volume.
Yeah. Some part.
Very interesting. So just from the femoral vein, you put one up in the SVC, one
Very
in the
simple.
IVC, and as long as you orient the valves right, it works.
Yeah, it's very simple.
Did you see in your studies a reduction in RV volume? Did you get remodeling as a consequence?
Oh yes, yeah, it does. And the taps improved, and the right ventricle function improved, and so we came on with this concept. We were not sure that it would work, but meanwhile another group in Berlin tried something similar. They used an Edwards sapien valve, because these valves are not that big as we need to. They first implanted a self-expanding stent in a cava superior and inferior, so they had a frame to put the Edwards sapien valve in. And they also report, it's published in the JACC, so that works, and that it improves the patient. So the concept is being proved also by another group, which is very important for us. Yeah.
What happened to right atrial volumes?
Okay, of course, in the beginning, the right atrial pressure increased. The volume, it's difficult to measure the right atrial volume, but on the long run, even the right atrial pressure decreased because the right ventricle restored.
Yeah,
for
very.
some part.
You wonder with this RV remodeling, it helps the tricuspid regurgitation of the native valve, and so maybe you need to make these valves removable.
Why? Yeah, no. they don't do any harm.
Right.
Actually, I mean, once they don't thrombose, it doesn't matter. Actually, if when the tricuspid regurgitation would be completely resolved, then they wouldn't work anymore, because they need the regurgitated flow to open and close.
Yeah, very interesting. Well, what's the next step for your research?
Oh, the next step is there's a huge clinical demand for that. I get emails week by week for physicians asking for that procedure. It isn't commercialized yet, so we are just allowed to do compassionate cases yet.
Yeah, well, it's really exciting.
It's something new, and
it's
I
new,
like to do these things.
And there's such a huge need for it, and it's a very novel idea. I think it's very creative.
Also, in your institution, would there be a great need?
Oh yes, yeah. We fixed the mitral stenosis or the mitral regurg, but they're left with this bad TR that they still.
Yeah, usually they are pre-operated patients, and in addition, many of those have pacemaker leads or defibrillator leads, and so we just compress those. I mean, we put the valve in, and the leads are beside, and it doesn't matter. So if you would really replace the lead, replace the valve, let's say with the orthotopic valve, you would run into trouble, because many of those have these leads.
Yeah, you're absolutely right.
Okay, we'll see.
Well, thank you very much.
Yeah, it was a
we
pleasure
really appreciate
talking to
from
you.
CardioTube and from CRT 2014 and Dr. Figulla, thank you.
Thank you.